I'm really honored to be here, truly, in Den Cooley Auditorium and seeing Texas Heart. I feel humbled. I'm going to talk to you about dogmas in cardiology, and I'm going to try and be a little provocative about the translation of science to the bedside. And I'm really coming to you as a consumer of science. Let me see if I can. Okay, I have no financial disclosures. Louisville, Kentucky is, I work in Baptist Health Louisville. This is the hospital I've worked at for 26 years. I started there when there was no EP lab, and been in the same EP lab for a long time. And I'm just a regular electrophysiologist doing regular things. I'm a practicing doctor. And like I said, I come as a consumer of science. I want to have a specific message to young people. When you're young and you're training, it's so exciting. You're learning these new procedures and you're focused on that, and I was too. And it was really a decade into practice before I started to see some things that I hadn't seen before because I was too busy learning to move catheters and wires and that sort of thing. And I guess a lot of my talk will be a historical tour through some of our mishaps. And, of course, the great philosopher Santayana said that those who cannot remember the past are condemned to repeat it. So one of my goals is to help show you some stories and maybe help in the translation of current evidence. Of course, I love evidence. It's what separates doctors from palm readers. But we in cardiology have developed these what I call therapeutic fashions, and I really got that from another doctor, and I'll show you later in the talk. I want to start my talk with cardiology's most important trial. I think it's medicine's most important trial, and it came about when I came into medicine. And at the beginning of my career were these PVCs in the CCU, and they always heralded bad outcomes. We were scared of PVCs. We had drugs that would suppress them. And so suppression of these PVCs became the normal thing. It just became the therapeutic fashion. But really, I started in the 1980s, but the story really began with Bernard Lown in the 1960s when the development of the CCU, and Bernard Lown organized some of the first CCUs where they treated PVCs arrhythmias before they caused trouble. And then 10 years later, we learned that observational studies showed association of PVCs, and more complexity of PVCs, the more likelihood of death there was. And so for a decade, it became normal to suppress PVCs, just became the fashion, until the CAST trial in 1991, CAST, antiarrhythmic drugs versus placebo. 1,500 patients who was a run-in period, so you couldn't get into CAST unless your antiarrhythmics suppressed the PVCs. It looked at serious endpoint, cardiac arrest or death. Look what happened. 3.5% absolute risk increase. And just to put your head around that, the number needed to kill patients with antiarrhythmic drugs was 29. Amazing turnabout of therapeutic fashion. But when I was researching for previous talks on this, I found this little paper in the Journal of Royal Society of Medicine. There's a older doctor there named John Hampton who wrote this story, 1980, about the therapeutic fashion of suppressing PVCs. In their little hospital in Britain, they did a little trial on lorcainide. Lorcainide rhymes with flecainide and encainide. It's a PVC suppressor, and they did this little trial of just 100 patients. They didn't even know about death. They didn't look at it, but they turned out that 9 of 48 patients on the lorcainide group died versus 1 of 47 in the placebo group. And of course, they stuck by the rules of science, and this is a hypothesis-generating thing, but they could not get this study published in 1980, 11 years before CAST. And they lost interest in getting it published, and the drug company lost interest in lorcainide, and it just went away. But later in the decade, more trials came out, meta-analyses showing that antiarrhythmics were hazardous. And so Hampton and his group published the results of their little trial 2 years after CAST, because it could get published then, because the therapeutic fashion had changed. And they wrote that the moral of the story is that evidence-based medicine depends on the evidence that's been collected according to the fashion of the day. And it depends on what can be funded and what interests journal editors and reviewers, and this is too a matter of fashion. And this is really where I got that whole idea of things getting ensconced as therapeutic fashion. Almost as bad a story as the antiarrhythmic drug story, though, is the prevention of coronary disease in women's story. So in 1992, the Annals of Internal Medicine publishes an observational study looking at hormone therapy to prevent disease, any disease. And in this paper, all of these observational studies are sort of meta-analyzed in a 1992 kind of way. And look what they wrote. There is evidence that estrogen therapy decreases risk for coronary disease. Check that causal language from observational studies. Hormone therapy should probably be recommended for women. This was in 1992. 15 million women were reported to be taking hormone replacement therapy in 2001. And then came the Women's Health Initiative, randomized controlled trial. 8,500 or so patients in each group, looking at a primary endpoint of MI and CV death, breast cancer as a safety endpoint. And look what happened. For every 10,000 people, there were 8 more coronary events, more PEs, more strokes, and more breast cancer. So again, those are just numbers, and it's easy to glaze over that. So I made a little slide trying to put into perspective what kind of harm that was from the observational studies, the therapeutic fashion of using hormone replacement therapy. And if you put 32 events over 10,000 and solve for X, you get 48,000 women were harmed because we paid attention to observational data that made sense. Okay, now for the hard part of the talk. The engine of my cardiology office, the whiteboard outside our nuclear camera, is filled every day. And Ali says, I walked by Ali, the nuclear tech, and he says, we're saving lives today, Mandrola. Okay, this is the search for ischemia. It's the engine. This is a real patient who had a coronary artery calcium scan and ended up in the cath lab with that lesion. And my partner, interventional cardiologist, turns out they're the most conservative cardiologist in our group, tried to take him off the table. So I'll come back to this picture, but let me take you a little tour from 1992 to this month. It really begins with the ACME trial in 92, plano balloon angioplasty versus medicines in single vessel disease, and again, no difference in cardiac events and maybe 90 minutes of exercise time difference, but of course it's an unblinded trial. 5 years later, in 1997, in The Lancet, is the RETA 2 trial. This is the most amazing trial interpretation I've ever seen. And I look at a lot of trials. This was plano balloon angioplasty versus medicines looking at a primary endpoint of death or MI. I'm going to show you the results. 6% in the PTCA group has an event, 3% in the medicine group. PTCA is worse than medicines, and it's statistically significant. So what were the conclusions in The Lancet in 1997? These were the conclusions. I kid you not, there's a cut and paste. PTCA, this was the first sentence, PTCA was associated with greater symptomatic improvement, especially in patients with more severe angina. They don't even mention that the primary endpoint was double. They say that when managing patients with angina, clinicians should balance these benefits against the small hazard. So this trial, again, I don't know how this could get in The Lancet. It's complete. It's the best example of spin I've ever seen. And then 2007, a decade later, comes the Courage trial, Bill Bowden. Again, no difference in any cardiac outcome 10 years later, same. Almost the same number of events in the medical therapy versus medical therapy plus PCI. There's been many sub-studies of courage, ones with positive nuclear scans, ones with severe disease, three-vessel disease and LV dysfunction. People talked about crossovers, and the investigators in courage have looked at them all and found no subgroup that did any better, no difference in any endpoint. And then comes ischemia trial, 2020, 2 years ago, 5,000 patients, double what courage had. And really a trial of strategies, delayed strategy versus an early invasive strategy. Randomization was before angiography, so you couldn't have the argument that they kicked out patients that had scary angiograms. They did do CTAs to rule out left main. That's an important caveat. Hard endpoints, and again, no statistical difference in hard endpoints in ischemia, 5,000 patients. In the subgroup analysis, even patients who had severe disease, no difference in intervening early. And what I'll show you now is my favorite slide of ischemia. The red line is the number of casts in the early invasive, and the blue line is the number of casts in the conservative arm. And so there's 75% fewer casts in the conservative arm, and with the same results at 5 years, same outcomes. And then 3 weeks ago at ESC, we get the results of revised BCIS. So 1992 to this month, or actually late August. This was a 700-patient trial of patients with ischemic cardiomyopathy. So you had to have multivessel disease and LV dysfunction, and you had to have disease amenable to PCI, and you had to have myocardial viability. So the translation of that is that these are the absolute best patients for PCI, and absolutely no difference in outcomes of death or heart failure. No improvement in ejection fraction. So this whole idea of doing a PCI to improve an ejection fraction in a myocardial viable segments wasn't borne out in this trial. So David Brown from WashU put up a little meta-analysis online, and again, you can see everything hovers. Every trial shows the same thing. And as far as angina, so PCI might be good if it relieves chest pain. Of course, the only sham-controlled trial of PCI in the Lancet Orbita shows that lesions like this, where patients were randomized to a PCI or nothing, and with proper blinding, there was a 16-second difference in exercise time, which didn't meet statistical significance. It's just shocking to me that opening a vessel like that in a patient with angina wouldn't relieve angina any better than a placebo. No difference in symptom scores, questionnaire scores. And despite all of his data, my partner took this patient off the table and told him he needed to take some tablets and he would be fine, and everybody went ballistic. The referring doctor went ballistic, the family went crazy, and eventually the patient had to went to a different interventionalist and got a stent. I got this 2 days ago from the Journal of American Heart Association. Mamas is a popular UK cardiologist on Twitter, and he posted this paper that they just did. Even in the UK, where there's no financial incentives, PCI volumes did not change one bit after Courage or after Orbita, and in fact, they're doing more patients with lower levels of angina and more patients in the UK who've not had stress tests. So David Cohn tweeted that financial incentives don't explain this pattern. I think the most likely explanation is that at the core, most interventional cardiologists don't really believe the trial results. And I guess I'd addendum his comment that most doctors don't believe it. And so my question is, how does this belief persist? And I'm throwing it out there, we can talk about it in the Q&A. I don't know why. If a neutral Martian came down and just looked at this data, If a new generation comes and looks at this data, I think they would just think, what are we doing? All right, now let's look at my field, EP. We're not innocent. The electrophysiology market is a major market. It's billions of dollars and growing. I mean, if you look at the amount of growth in EP, it's crazy. So this is a patient of mine, his ECG. And obviously he's in atrial fibrillation. He's a 62-year-old fellow who does CrossFit. I mean, he's super fit. Before I did his 2 ablations, he was completely incapacitated by his AFib. He was crying with AFib, just terrible. And he came to me and he said, "Thank you, I now feel great." And that was his EKG. So, okay, what are we doing? Let me tell you a story about AFib. This is the seminal trial that started AFib ablation from Hasegary's group in 1998 in the New England Journal of Medicine, where they ablated focal lesions in the pulmonary veins, 1998. During follow-up, 62% of patients had no recurrences. Okay, 20 years later, with all of the innovation that we've had in catheters and mapping systems and everything, in Cabana, which recruits the best centers in the world, okay, here are the results of AFib ablation. And you can see that the yellow line ends up at 4 years at about a 50% success rate. That's over 20 years of innovation in AFib. And I guess my proposition to you all is that this is because we don't understand what causes atrial fibrillation. This is a slide that I got from Ed Gerstenfeld, and you can see I circled the dates. We're still arguing about the mechanisms of atrial fibrillation, and look at those dates, 1962, 1947. Heart outcomes. Okay, what about heart outcomes? We do a lot of AFib ablation. Are we making people live longer, have fewer strokes? Cabana randomized 1,100 patients in 126 countries, looked at a hard endpoint and followed patients for 4 years and found that in the proper attention to treat analysis, there was no statistical difference. A 14% relative risk reduction, but wide confidence intervals and no clear benefit in hard outcomes. What about, my colleagues will say, well, Mandrola, we're suppressing AFib. We're suppressing AFib. This is a good thing. So I show you the Circadose trial. This is Jason Andrade's paper he's from the UBC. And they did a 3-arm trial looking at RF and cryoballoon. And again, if you look at first occurrence of AFib, it's still 50% success rate. But Jason and those guys thought they do is they would look at AF burden because all of these patients had loop recorders. And indeed, if you look, cryo, RF, all of these patients had low burden AFib that went to almost no AFib on their loop recorders. The problem with these studies, every single one of them, is we don't have a control arm. We don't have a no treatment arm of the AFib. And you might say, well, that's crazy. Why would you do that? Well, a couple months ago, I met Søren Didriksen. Søren Didriksen is this young Danish guy who I thought, he's published so many papers, I thought he would be like somebody my age, but he's a young guy and he's published really interesting work on subclinical AFib from loop recorders. One of the authors of the loop study. And he found that when you look at people with low burden AFib, 55% will have reduced AF burden over time. And 1 in 5 patients with low burden AFib will have suppression, will have elimination of the AFib. The natural history has gone away. So that's why these AFib ablation studies that don't have a control arm bother me. My afibrillation proponents will say, well, look, John, about Castle AFib. Castle AFib was heart failure and AFib ablation. And so they randomized patients who did not respond to antiarrhythmic drugs, had adverse effects from antiarrhythmic drugs, to either taking antiarrhythmic drugs or having ablation. So again, this was a very, very strongly positive trial, reducing death, heart failure hospitalizations in both. But the problem with Castle AFib is that They screened 3,000 patients to enroll 300. So 1 in 10 patients were recruited. As underpowered, missing data, and the primary analysis is based on just a small number of events. And if this was a heart failure drug trial, it would never pass muster. Well, what about quality of life? You make me feel better with ablation. Well, it's the number of randomized controlled trials showing AFib ablation improves quality of life over a placebo procedure. There's none. Now, the good news is, and I've been arguing for a sham-controlled and Orbita-like AF ablation trial for a long time. The good news is that there are actually 3 ongoing randomized controlled trials looking at sham procedures, 1 in Germany and 2 in the UK. And so we'll get an idea about the placebo effect of AFib ablation. And of course, the other problem with AFib ablation that I've heard about people working on here is that 51% of AFib ablationists have had a patient develop atrioesophageal fistula, and often a deadly complication. Again, it's a rare complication, but these are 40 to 50-year-old people we're ablating. And so the bottom line is the problem with AFib ablation may be existential. And when I debated Rob Cowell, who's now the CMO of Medtronic, a number of years ago, he said in one of his papers, AFib is a final common electrical diagnosis for multiple different primary diseases. So we may not even be ablating, we may be ablating a symptom rather than a disease. Okay, now we have to talk about appendage occlusion, which is going crazy in Louisville. I don't know what it's like in Texas, but in Louisville, the idea of plugging the left atrial appendage to prevent stroke is a very popular procedure. And in fact, the registry studies will show that there's been, this is old data, but there's been at least 50,000 Watchman procedures done in the US, average age 76, CHA2DS2-VASc 4 to 5. So very sick elderly people are getting this procedure. You see ads on the internet and on TV for Watchman, and more patients will come and ask, what about that procedure? And I've debated Watchman as the contrarian on 5 continents, and I have 45-minute presentations on why Watchman is a bad idea, but I've been able to get it on 1 slide. So I'll show you the argument against this procedure on 1 slide. The PROTECT AF, which was the seminal trial, didn't pass FDA muster. FDA said, you got to do another trial. So they did another trial. They did PREVAIL, and they borrowed patients from PROTECT AF. And PREVAIL missed its non-inferiority endpoint because ischemic strokes were higher. So the stroke prevention device actually led to having more strokes when compared to warfarin. When you look at bleeding and you count the procedure, bleeding rates are the same. No difference. This is the Holmes meta-analysis that's often cited. If you look at real-world data, complications, patients start this whole probabilistic gamble with a 5% complication rate in the best of centers. And then remember that when you put a plug in the left atrial appendage, you have to use antiplatelets. But it turns out that this whole idea that aspirin is any more safe than apixaban really wasn't borne out in Averroes. Averroes is one of the most important AFib studies there is. Averroes took patients who had a contraindication to anticoagulation or whose physician didn't want them to take anticoagulation, and they randomized patients to apixaban versus aspirin. And of course apixaban reduced the stroke rate. That was the primary outcome. But I've copied and pasted the bleeding rate. Look at the bleeding rates on aspirin and apixaban are no different. So the idea that forcing someone to take an aspirin is any safer than apixaban is not really borne out when you look at evidence. And I picked this paper up just from last week from Jack EP. This is a registry from Europe, 800 patients who had Watchman. And what they were interested in looking at, what's the death rate after we put in, what's the 1-year death rate? They called it early death. And they found that 1 in 6 patients in Europe, which are probably more selective than us, 1 in 6 patients die in the first year. And if you have more than 3 of these risk factors, there's a 30% chance of early death. And so even if you believed this procedure worked. I don't, but many people do. Patients having this, older patients with risk factors who are going to have early death, they're going to get no benefit from this procedure, and these are the ones that we're doing. It's crazy. Quick story talk about therapeutic fashion and talk about being fooled. We're a referral center at my hospital for cardiac arrest. We see a lot of resuscitated cardiac arrest, and one of my partners is really into the community on cardiac arrest, and cooling was such a huge thing. I called it the popsicle thing. I went and looked at how this got started, and it got started in 2002 with 2 trials. One had 77 patients, 33 degrees versus normal, and they found this huge odds ratio of 5.25 better outcomes with cooling. And there were all kinds of concerns with this small study and no control of fever, all kinds of problems. In the same issue of the journal was another study, a little bit bigger, but again, the same kind of findings, a 40% relative risk benefit from being cooled, and like a 14% difference in death. And so you have these 2 trials that show this effect from cooling. But as a sidebar, I just want to show you this paper that I keep on hand. This is from the Stanford group, doing a systematic review of studies that find systematic reviews that find large effect sizes. So they went and looked at studies that had odds ratios greater than 5, and what they found was that most large treatment effects emerge from small studies like the ones I just showed you, and when additional trials are performed, effect sizes become typically much smaller. So let me finish the story about cooling. So these 2 studies led to a change in guidelines, widespread acceptance, and hypothermia became hot. In fact, when I did my ACLS a couple years ago, target tissue temperature was on the ACLS AHA protocol. Well, then in 2013, 10 years later, comes out the TTM trial, a little bit bigger. Here, a little bit bigger trial, a little bit better trial, no difference in neurologic outcomes. And the authors write in the conclusion, our trial does not provide evidence that targeting a body temperature of 30 degrees confers any benefit to patients compared to 36 degrees. But nothing changed. We still cooled patients. 2013 was a long time ago. We've been cooling patients. Well then, last year came the TTM2 trial, now with double the number of patients. And again, 33 degrees cooling versus normothermia, and again, no difference. In fact, there were more arrhythmias, more paralytics in the 33-degree arm, longer ventilation time in cooled patients. So not only was there no difference, it was probably harm. So it's more invasive, more labor-intensive, requires more sedation, may increase the risk of bradyarrhythmias, and 2 large trials show no benefit. But this is the accompanying editorial in the New England Journal of Medicine at the TTM2 trial. The key takeaway from this TTM should be that target tissue temperature and timely neurologic prognostication is a crucial treatment strategy. The target temperature at the discretion of the clinician could be 33 degrees, 36 degrees, or 37 degrees. So even with all of this data, editorialists are not convinced. Finally, primary prevention in the ICD and non-ischemic cardiomyopathy. I want to just pose a question. This is my final story. We'll have time for questions. Do you offer an ICD to a 75-year-old female with non-ischemic cardiomyopathy, a narrow QRS, and an EF of 25%? Who says yes? Hands? Who says no? No? Yes. All right. Well, I can just tell you that guidelines would say, go ahead. And I want to show you, this is a paper that really moved me when I started writing. When I started writing about ICDs back 10 years ago because I saw a lot of overuse. And this was a paper from Mark Josephson, Rod Tung, and Peter Zimmerbaum from Harvard in 2008, and it's buried in JACC, no one cites it. But it was written during the period of irrational exuberance when ICDs were going crazy and companies were training non-electrophysiologists at weekend courses to put in ICDs. And they wrote, despite the inclusion of non-ischemic etiologies into the class 1 indications, not a single trial has demonstrated a statistically significant mortality benefit in this group. And they went through an argument and they said the inclusive nature of the data that we mentioned calls the class 1 indication into question in this population. So they called it in 2008. There are no ICDs. There are no RCTs with only non-ischemic patients in which ICDs have been proven beneficial. The two early trials, CAT and AmioVert, were null. Definite trial. This was in 2004. It was enriched with patients who should benefit, right? Low EF, 21%, lots of non-sustained VT, and even when you enrich it, they couldn't get a statistically significant result in non-ischemics. In SCUD-HEF, one of the seminal trials, if you look at ischemic, there was definitely a benefit, made statistical significance, but when they separated out, and this was a pre-specified subgroup, when they looked at non-ischemics, they couldn't show significant benefit even though there were 1,200 non-ischemics. So this topic makes me think about time limits of trials. Should trials have a time limit? And SCUD-HEF enrolled patients in the early 2000s. But of course, medical therapy has gotten better. We have lots of new drugs. We also have this secular decline in sudden death rates. And let me show you this paper. And also, this paper sits in New England and doesn't get a lot of press. This is a heart failure trialist who published declining risk of sudden death. And what they did is they looked at 12 randomized controlled trials over the 1990s to 2014. And what they showed is that there's been this huge decline in sudden death over time. The cumulative incidence of sudden death was 2.4% in the earliest trial and is now 1.0 in the most recent trial. So we're just doing things to make people not have sudden death as much as they used to. And then comes Danish. So Danish randomized 1,100 patients with proven non-ischemic cardiomyopathy, followed them for nearly 6 years. These patients had a 25% ejection fraction, and they had really good baseline therapy. And look what happens. Absolutely no benefit in the best trial we have. And Danish hasn't made a difference. I don't know why Danish hasn't made a difference, but it hasn't. Guidelines haven't changed, and people still put defibrillators in non-ischemics like it works. And this is my final mention. I have so much so many stories I could have told. So here are a few that I left out of time. So sacubitril valsartan, which is huge, has one positive trial against enalapril. All other trials of sacubitril valsartan have been null or neutral. PFO closure, we all do PFO closures. When you look at PFO closures, the missing data in the most recent trials is greater than the fragility index. Cardiomems. We're doing cardiomems in my hospital. Cardiomems, the GUIDE-HF trial was null until they did a pre-COVID analysis of GUIDE-HF, pre-COVID. FFR, we do FFR, we do this all the time. But I dare you to go look at FAME and FAME2 and tell me that you really think FFR holds up. I've given a talk defending digoxin. I think that digoxin has been maligned because of observational studies. And finally, the CHADS-VASc score. I could have showed you slides on the CHADS-VASc score. We use this every day, and when you look at the evidence, it's not there. So finally, this is Dr. John Lloyd, who influenced me greatly because he sat me down one day in the doctor's lounge. He's now retired. Dr. Lloyd would come in the middle of the night looking like that. He was a pulmonologist. And he sat me down and told me one day that we don't control outcomes like we think we do. And so when we wrote our case for being a medical conservative, we wrote that the wisest of conservative physicians understand and embrace how little effect the clinician has on outcomes. And we wrote that some would call this nihilistic, but we see it as protective against our greatest foe, which is overconfidence or hubris. And with that, I'll close and yield the floor for 15 minutes for questions, and I really appreciate the opportunity to come and speak at this institution. Thank you very much.